Hello class, my name is William Ross and the subject of my presentation is prescription drug monitoring programs and their effects on the opiate epidemic. So the opiate epidemic is a huge deal because we see even some of my friends from back home falling victims to it. In 2015, more than 33,000 people fell victims to opiates, and almost half of it were because of doctor prescribed opioids. There's a relationship between opioid pain prescriptions and heroin use. The CDC reports that 45% of people who used heroin were also previously addicted to opioid painkillers. And even Washington Post claims that prescription painkillers are more popular than tobacco in today's adults. An overview of the specific policy: prescription drugs are being abused. People are doctor shopping. They're going to different doctors to try to get more drugs. And even doctors are wrongfully prescribing people. Um, and this all leads to more addiction in prescribed painkillers and heroin. What is there to prevent this? The DNA gave pharmacists the right to exercise their professional judgment to determine whether a prescription for a controlled substance was issued for a legitimate reason. And we also have implemented prescription drug monitoring programs, and mainly they identify patients who are obtaining opioids from multiple providers, and they just give us general statistics on opioids going through the system. Inspect is an example of one. Its main focus is to improve the hospital physicians' access to prescribing patterns for patients in Indiana. This has to do with my study, which was done by Connor Norwood and Eric Wright. The title is Integration of Prescription Drug Monitoring Programs in Pharmacy Practice, Improving Clinical Decision Making, and Supporting a Pharmacist's Professional Judgment. It aims to prove that Inspect promotes a change in practice to dispense fewer controlled substance prescriptions. It increases the likelihood of a pharmacist to report having refused to dispense a CSP, and whether and to what extent more consistent use of Inspect influences a pharmacist's total annual refusals of CSPs. It is believed that pharmacists who use Inspect are more likely to deny CSPs, as these statistics that they get from Inspect support their professional judgment. The study methods: they got 10,606 providers from Inspect. It was a cross-sectional study. It was done through a survey. Only 15% responded, but they combated this by comparing it to 2012 Indiana pharmacist workforce data to ensure sample was representative of Indiana's total pharmacist population. The primary independent variable was whether or not Inspect led to their dispensation change. Outcome measures: dispensation change, refused dispensation, and annual refusals. Used multiple logic. They used multiple logistic regression to examine the relationships between PDMP use and pharmacist controlled substance dispensing behaviors. I would like to note that Farm D, M Farm, and B Farm are all different stages in which the doctors have studied. He uses this to break it down also. But the evidence of effect is that informed providers refused an average of 25 prescriptions, and uninformed an average of 7. As you can see here, this is a list of frequency of factors leading to a change in dispensing practice of controlled substance prescriptions. Um, Now, the top one is new professional practice standards and protocols, but then under that is Inspect. Inspect provides greater access to patient prescription drug history, and it really allows them to back up the regulation that the DEA gave them. Here, this is interesting. We see that down at the bottom, have you ever used Inspect? We see um, a startling amount that say no, and this is something that should be dealt with. As I said, 25 controlled substances, denied for informed people, and 7 refusals for uninformed. Um, Pharmacists using Inspect consistently were 3.3 times more likely to refuse to dispense more CSPs than uh, than those who never reported using Inspect. And lastly, Inspect has influenced a reduction in controlled substance prescriptions in Indiana, and even goes as far as suggesting PDMPs provide more information to pharmacists to help inform and support their professional judgment to exercise corresponding responsibilities. This study implies the knowledge of PDMPs leave providers more likely to refuse CSPs. 49 out of 50 states have a PDMP, yet they are providers that don't use it. There needs to be a better way to manage pain. For now, in order to attack the opiate epidemic, there needs to be a collective effort to reduce the amount of painkillers being prescribed, and it starts with the reports that the providers gets, and successful implementation must be studied to fully understand the implication of the study. Is my work cited? Thank you.